surgeons have deliberately made it complicated. I would call Noor Priley a curse for deformities because he has really made a simple thing very, very complex, and you go to the lectures, you'll fall asleep. Today we are having two diverse opinions. One is Dr. Jishnu Baruah from Deformity Classification, and one is Dr. Jhunjhunwala. Dr. Jhunjhunwala has got probably India's largest collection and experience of deformity corrections, and his talk is outstanding. And Jishnu Baruah does what we call the gardening approach, because he says that Ilizarov doesn't come out of geometry box or computer software, it comes out of common sense and respect for soft tissues. So we are going to have Dr. Jishnu Baruah to speak about the principles of deformity correction and a new classification of deformities. And then we have Dr. Jhunjhunwala, who will complement it by a long talk showing you how exactly to apply frames and what way to correct deformities. Again, we have taken the message from the delegates. The faculty has been instructed that they won't be showing what they have done. They are going to teach more of how you can do it. Yes, we all know that we have got a distinguished faculty, we have got exceptional results, and Ilizarov is a magical thing. But then rather than wasting hours and hours with slides of showing remarkable results, which it is capable of producing, let us fulfill the basic premise of this basic workshop to teach you how to actually do it. Dr. Jishnu Baruah.
Good afternoon. I'm really honored to be among the galaxy of stars, everyone, that I'm having the opportunity to present my opinion on this thing. This is a topic that actually has really bewildered me. I mean, when you go through the literatures of Ilizarov, all the books in the 70s, 80s, and the 90s, there comes a time when it becomes too difficult to comprehend, and then it scares away surgeons. But when you start doing it, you find that the rules have maybe unnecessarily been complicated, and you can do with much lesser direct approach by going back some steps, some decades back. So let us first come to this book that I have found a little bit hard to understand after trying to read many times. And then we start with the learning objectives of today's talk, that is a brief review of the literature, because that will highlight the problem. And we propose a practical approach to deformity correction, because otherwise we will not get people to start doing it if you follow those things. And of course the future scopes, which you will decide after this talk. So deformity correction has been dealt adequately with in all the books in the 80s, 70s, till of course Assami. This is not a talk of Assami principles versus Russian principles. It's an amalgamation of things that are working in both the systems. Okay. When one goes through deformity correction mechanisms or frames, one comes across basically two types of constructs: one push-pull and another the hinge method. And on a superficial look, it looks have to have a more space. Some stability issues will be there because this is not a correct way to make a Ilizarov frame that we have learned today. And controlling the rates will not be easy with the geometrical calculations that are given. It's sort of many pushers, many pullers. So, and the safe corridors, it actually does not respect any safe corridors. If you have a plane of deformity on the corner plane, you will be putting your K-wires vertically. That means that doesn't. So the other hinge method comes from an optimum anchorage. It has a controllable rate that can be calculated geometrically, but has space restriction. There are cylinders with 2 centimeter gaps around the limb. Even if you kink it, on the convexity, look what will happen to the soft tissues. I mean, there's no space, but it will have strength issues, unlike the other method, because your forces will be taken up by one distracting rod or one contracting or collapsing rod, and that rod, if it fails or a thread slips, then it will be lost. So it will be less stronger than the other one, definitely. But hinges are not only of the other principle. Hinges were there from Ilizarov's time, but the way he used these hinges were based on certain things that you have to understand. He used these diagrams, simple diagrams. Their formulas are difficult to understand, but what they mean to explain is very easy. When you try to hinge here at the apex of deformity and make it straight, it becomes distracted and correct. Okay, the point is important. A, when you hinge a little bit away, you have still more distraction because it distracts the cone of tissue that includes both the sides. And when you distract a little bit towards the concavity, you will have alternate type of distraction here, but the axis is corrected in both. You have to understand that the axis is not drawn here. It was not difficult to draw axis in those times, but he omitted drawing axes here. Okay, but he gave the basis of the rule 2 that came in the 90s. Rule 1, sorry. And then he talked about hinging a little bit up, having a long swinging arm that leads to a shift in the direction of correction. If you can see, this is a shifted bone. It has been shifted towards the direction of correction more. Now, the second is if you hinge a little below, having a shorter swinging arm, this shift is on the opposite side. And finally, if you do that little up, but still with a longer swinging arm, you have a shift as well as a distraction to your requirement. So these are the only 2 cardinal rules of deformity correction that need to be understood. Whether you want to have an angular correction alone, or you want to have an angular correction associated with a shift. Now we'll come to the clinical situations. And in the 80s, when things started to come more clear, we had more friendlier pictures that talks about the translation or distraction hinge that are the same thing actually. And the translation hinge, hinging a little, compression hinge here, sorry. And the translation type of hinges that hinge a little up here or a down. So basically this is a follow-on of the same things. They still avoided drawing the lines and the geometries. But they are self-explanatory. They explain everything that you need to know. Apart from that, they talked about a little bit of translation and shifting correction that can be adopted with applying peri-mounting devices. But how practical this is will be difficult. But you can, if you master it, if you understand it, maybe you can apply it to a little degree. But these hinging techniques are enough to do. So then come the 90s with some mathematics, alien mathematics, that really sort of, I never know how anybody can actually apply this. Maybe with a autofix or something like with a computer maybe, but not in our situation. I mean, I will never be able to understand it in my lifetime. And so, but we are doing correction actually. That's why I was trying to tell you that what we are doing. We are proposing a simple type of uniplanar, these 5 types, uniplanar angular diaphyseal deformity. It is not AP or a lateral plane. It is an angular simple angular diaphyseal. Why diaphyseal? Because it has got no fixation issues, it's towards the middle of a bone, and it is an angular uniplanar angular. It can be a mediolateral or something else, but it is one plane. Then uniplanar angular juxta-articular near a joint, where you cannot have the correction at your desire. There will be joint coming into place. There will be a metaphysis where you have to have an anchorage, optimum anchorage. So your correction will be still below. While doing it still below, you will compromise on the axis. There will be shift of the bone. But we already have the solution from the first slides. We can encourage shift in a direction. And then we have the multiplanar angular deformity that can confuse you. Because which is the plane which to be attacked, where to put the hinges and where to put the distractor and where. So there is a third type where it is multiplanar angular deformity. And angular deformity coming with rotation can still be a little bit more problem, where rotation should be addressed after or later on, that becomes the issue. And then complex multi-joint deformity, which includes contractures like congenital CTEV or Barn contractures or other defects, which have to be tackled individually according to case wise. So when you come to uniplanar angular deformity, it's the simplest, but it's not the commonest. No issues with the plane of deformity. You can get it. It is in front of you. You take an X-ray in the profile of the deformity, you get the plane. That is the plane where you have to work on. That is the plane where you have to draw the bisector, find the apex, take out the coda and put the era or something like that. But you don't have to take a AP and lateral and then get that plane. It is in front of your eyes only from the first day. No issues of hardware occupying proposed osteotomy site because it is diaphyseal. And of course, issues with the joint orientation line or axis. Suppose I want to draw axes on those deformed lines. I can only draw it from an AP and lateral joint line. I cannot draw it from an oblique. If the deformity is in an oblique plane, the joints will also be in an oblique plane. So I cannot see them to draw proper lines from them. So you cannot use them. So the joint plane reorientation approach can be used where just the knee joint ring is applied parallel to the knee joint here, and another parallel to the angle is applied. These are things that can be achieved on the OT table. They don't need complicated software or some calculations. They are based on anatomical landmarks and correct orientation of the ring and maybe the help of an IITT. After doing that, you can create the axis of the ring towards the apex of deformity from those basic rings. And that axis, if you are putting the limbs or the segments in the center, will guide you to the bisector plane automatically. They don't have to be drawn on a paper and then translated into bone in a OT table. You simply make them correct because the ultimate aim is to have an ankle joint and a knee joint parallel to each other. That is what the frame is already going to guide you because the frame itself has an axis, which is the rods, connecting rods. If they're very close together, then you put up your hinge, you will find that the hinges will be pressed into that plane automatically, which is represented by a bisector line. And then this makes the anchorings very important. You have to use those anatomical landmarks here to shin the fibula like that to get it in correct orientation, and then you can use the other side to template, and then you put the strong fixation parallel to the knee joint. And the distal side also you act like that. You put a strong anchorage, get it in correct orientation relative to the other foot or the normal foot leg, and then once you get those two links, the only thing that is left to do is to align them properly. And we have already those two cardinal rules that can be applied. I'll show you how. The fixator then becomes a jig. I'm telling you, these have been applied like I advised, and you just go along the axis, build up towards the frame. You'll find that they will be touching each other. Okay? You construct the frame towards the apex deformity, and the midline you will have this line, which will be the farthest and the closest. This line. It's not a line actually, it's a plane. It's a circular plane. Okay? The middle links automatically will guide to the bisector plane, and the hinge connectors in the corresponding holes. If you use the corresponding holes here, this ring and that ring, suppose the fourth ring from this midline, fourth hole from this midline, if you connect, they will always be hinged here because they are forced to be at 90 degrees to the. So wherever you put those connectors, they will be always forced into that plane. That you get it automatically. So choose compression distraction or neutral, just like Ilizarov and Kolyakovsky's book taught us. You can put it in the convexity side, distraction, and distract here to get distraction. You can put the hinge here and compress here to get compression. That's just very simple. But remember that you can have a pair of them because you are working on a plane, not a line. So you have a hinge here and there on the other side, like this, and you can have a distraction. This finishes. Now the rate. The linear distraction is said to be 1 millimeter per day, divided into 4 doses. But in angular distraction, you will be distracting a cone of tissues, so they will be distracting at a different rate. You may not get 1 millimeter by distracting 1 millimeter in the hinge here. The rule of similar triangles gives you a very easy way to calculate that if you need to distract 1 millimeter somewhere here, by the rule of similar triangles in this diagram, you have to distract twice the amount here because the bases are in relation to 3:6, that is twice. So if this is based from distance from here to here and here to here is double or 4 times, you have to distract likewise. But that will guide you to the initial day of distraction only. Later on, these angles will change, and then you have to do the calculation again and again every time. To get it more accurate, it has to be an angle-based formula, which brings into again those alien mathematics. Then these are the things that are very important when you have to consider correcting this angular deformity. If you do not take your distraction properly at the soft tissues, they will be contracted and they will cause secondary deviations. So like clawing of toes while correcting this equinus deformity. These are the things that are not being actually addressed, the issues of soft tissues. It is bluntly mentioned that it can be distracted 2 to 4 millimeter per day, but then the rates can be very much variable. So if it is a vital organ like a common peroneal nerve or some other nerve that is in the cone of tissues that are getting distracted, then they have to be taken very due care of. Otherwise, it's more important to care this vital structure than take care of those bones at that time. So, but whatever it is, uniplanar, it will be very useful for uniplanar deformity like this. Both mechanical and anatomical excesses can be corrected. This is the basis of the astronomy rule 1, that actually is the follow-up of the first only, and this is an example. In excessive deformity, what if they do not intersect at the bone? Where you make the cut? There is a rule called osteotomy rule 3 and its corollary that says that you can make suitable cuts at two other levels. These are the resolution chorus, or not the resolution chorus, multiple chorus, linear anatomical axis in the between. These are the mechanical axis, and you get a, you need to do a correction here, correction here, then you will get a good correction. But this will lead to, this is a small child, so this will lead to fixation issues. So you can, by using the corollary of the rule 3, when you go through the books, you will find that you can do it at one point and have a correction. That will be more suitable than having multiple okay, walking for the first time, but main is later on. So this is what rule 3 was all about. I mean, I don't want to read it because it is available everywhere in every literature. It talks about making two coras and cuts in two different levels, but also this essentially means then you can do a corticotomy anywhere. I mean, rule is sort of difficult to understand because you can make the anatomical axis in this line or that line or that line, and that makes you make two coras at your choice. So there is no fixed point. You can choose your corticotomy at any point. That is what the essence is. It will obviously lead to fixation issues if you make multiple corrections. The corollary to rule 3 says you can do it at the resolution cora, that is more useful. So next come to the second part. It's the juxtaarticular articular deformity, which can lead to very confusing situations where you cannot do a osteotomy at the site of where you desire. You need to do it a little bit below because you have to accommodate the fixation, and also cannot do a corticotomy at a joint, isn't it? So what will happen is it will compromise. It will shift the axis of the limb, and corollary to like this. When you need a shift, it can be intra-articular or it can be extra-articular deformity. It doesn't matter. But the thing is that you have to do a corticotomy at a place which is not your choice. You'll have to do it below, and that will you will encounter a shift here. So that tells us, that gives us, the rule 2 gives us an option that we can either shift our hinges a little up or a little below the so-called translation hinges of the earlier literature, so that we get a desired shift on our desired direction. Like this example, where the hinges was done here, so that the shifting was on the opposite side, and here those who are doing high degree osteotomy and other things will understand, will like this, that the hinging is actually nearer to the deformity, but the corticotomy is elsewhere. So ultimately, after correction, there is a shift. This is a desirable shift that is induced. So hinging without shift, hinging with shift is the two things that you have to understand and apply. Like in supramedullary osteotomy that was done, if I simply correct it here, that will be a big medial sided bump that will not be very suitable. So if we need a lateral side translation, so that means when we do the corticotomy but hinge here a little below, I have a shorter swinging arm. That is going to effectively shift this towards the opposite side. And this is what actually happened without any medial bump or minimizing the medial bump. So this is rule 2 type of correction, juxtaarticular type of correction, where you are trying to play with the shift. Another example where you actually using a longer shifting arm, because this is where we need, besides correction, you need an anterior shift. Okay? So you use a longer shifting arm here, swinging arm, the hinge is a little above. So it shifted anteriorly. And it addressed also the shortening as well as the equinus, and everything got corrected to make her more presentable. So I'll just have an exercise for you. This is shows tibialization of fibula for some reason. I don't remember why, because there's some. So I need to correct here. I shift it here. In effect, I have a shorter swinging arm. So where do we predict that the fibula is going to go? I have a shorter swinging arm, so the fibula is going to shift to here at the time of angular correction. A series of X-rays that shows that keeping the hinging at this point, it can actually shift it. This is perioperative and this is the actual prediction. It still, however, did not answer the rates at which the common peroneal nerve actually would tolerate, because one day suddenly he developed palsy and we stopped it and put him in a cast. And the multiplanar angular deformity is the one where the plane of deformity do not show the joint orientation. It's very difficult to make which axis to use. You are forced to use anatomical axis, which is not desirable, ignoring the joint orientation. Here the osteotomy rule 3, which means doing a correction at a resolution point helps us. Multiplanar angular deformity, for example, a varus and procurvatum at the same time, okay, will lead to different poras in the AP and lateral views. Logical approach is to make osteotomies at individual level, procurvatum, after correcting one, the procurvatum becomes recurvatum. So the thing is, you cannot simply convert a deformity into AP and lateral and then do it in AP and lateral. You have to act on the plane only. For example, AP and lateral have different poras here. If you're drawing from the joint. So when we use the joint plane reorientation, of course, in this case also, we go for the ankle and the knee, and we build up the frame towards the apex. It guides us to the plane where we need to do the osteotomy, and then we apply, if it is going collinearly, then you will apply the rules of type 1, and if it is a shift, we will apply rules of type 2 and get a required shift. And type 4 angular deformity with rotation, I will deal with only the leg part, the femur, I mean, she needed correction everywhere. This was the normal X-ray that she came with, but when we did her profile X-ray, it became like patella. The problem is with the knee as well as the ankle, everywhere. So she needs a femoral correction as well as a tibial correction, and everything will at the same time will be very much cumbersome for the patient. So one by one we decided to tackle it. I corrected the femur to get a relatively straighter knee, and then we act on the tibia to get with Ilizarov to get the desired anterolateral shift. Here what we did was her tibia was internally rotated, so on table we derotated it before we fixed the hinges, because it is a rotation of a normal anatomy, it's abnormal, so derotation is much more accepted because it is actually restoring the normal anatomy. And when we put it, the distal ring in the orientation of the deformity, and then we corrected it externally, it became like this, and we fixed it up, something like this, internal rotation became like that. There is no limit. They say that 20 to 30 degree can be derotated, but derotation of a deformity is actually restoring anatomy, so much more is tolerated. And then it becomes a simple case of type 1 or type 2 correction. All you have to correct the angular deformity. And here, when we go to the literature, we find that angular rotation should be corrected last. That is what the advice that is given in all papers. They say that rotation is achieved by, derotation is achieved by doing it between parallel rings. That is the reason. But it is also mentioned in these books that when you derotate, you induce shift between the translation, shift between the fragments, because the fragments are not concentric to the rings. And when you do derotate at the last, your regenerate is going to shift badly. Also, twisting or derotating a freshly formed regenerate does not have much biological sense because it can damage a lot of things, and it is not advised also. Such complex frames are also described, but they are not very easy to apply, nor they are suitable to control, and they are not stable also enough. So our technique of actually correcting rotation first and converting it into simpler angular deformity and then getting correction is working much better. Here there is just a mention where the translation effect of derotation is mentioned like that, even shown by diagrams, that we cannot derotate at the last, it will cause translation. So derotation has to be addressed in the first, that is what our suggestion is. This is an example of internal rotation. We corrected almost 60 to 70 degree here gradually, but we did monitor this case when we did it. And after that, we simply did a lengthening. This was not necessary to do any angular correction in this case, but derotation at a corticotomy can be done because it can simply not harm anything. And final fine tuning is always there because of this effect. We can always translate at the end or rotate or derotate at the end to achieve the perfect reduction before the start of the consolidation phase. So we always have to, this complex multi-gen deformity last group does not include those where no rules actually can be set. We have a soft tissue component than bony. It spans across many joints and tiny releases and constant readjustment has to be done, and actually no rules can be laid down. The most important common example that I can say is our effort in correcting neglected CTV with the Ponseti technique where Ponseti is very difficult to apply. So we are using the fixator to do his maneuver, the maneuver that he suggests, and people are, we're having a bunch of kids that are quite happy and tolerating this instrument because they are tolerating it much better than plaster cast. It's very difficult. We first achieve the forefoot correction, and after that we do the equinus correction, just like Ponseti is saying. So this was a case where planning was needed because it was an atrophic limb and a deformity with a stump that was in the middle of her leg. I mean, with an atrophic limb, it was not possible to get much of 9 centimeter, 10 centimeter landing. We were not sure how much that limb is going to behave like that. So what we did was we corrected by corticotomy only 6 centimeter, that is advisable. And then we decided that she has this useless stump of leg that can be pulled down and then fused to the distal end of the tibia or fibula where she was walking. So a complex type of deformity can be, by constant adjustment of frame, we can get our desired tissues anywhere we want. So the final slides, not moving at all. Okay. This was our pre-operative surgery, and after 7 months to 1 year, she came back. She was in her school uniform, and that was nice because she never felt like. Articular deformities are also belongs to this category where a lot of it can occur in all planes. So a lot of things has to be adjusted, but Ilizarov gives you that affordability. Flexion, abduction, external rotation. This was corrected by a pelvic support osteotomy and subsequent lengthening, and a case of tuberculosis hip that was in deformity. Flexion, adduction, internal rotation deformity was corrected by arthrodesis to have equal limb length, and deformity correction to mobilize early. So in forearm deformity correction, all I would say that we should not go for too much of anatomical correction of the forearm. Function is more important. And to highlight this, we have used this technique, like this was a case of osteochondroma masada type 2B with compound radial proximal radial dislocation, which is very rare. That much of neglect is very rare, but we decided that as it was so late and her growth potential was not much, simple lengthening of the ulna would suffice. Even that, simple lengthening of the ulna had to be done in multiple steps because after some day it became stiff, and then we had to stop, go for physiotherapy and got the finger movement, and then again we started like that. And after that, we decided that putting this fixator for the consolidation phase is going to hamper her function. So we took it out and then put a plate, lock plate. With the advent of lock plate, I am doing it more and more during after distraction phase. We just release it and put the plate, and that helps us to get the function better. Particularly in the upper limb, forearm distractions or the femur, where the consolidation phase can be too long and the pinflex can cause problem. It is better that after the distraction, we can put a lock plate. It's very strong and more acceptable to the patient. But in the tibia, as the anatomical and the mechanical axes are same, it is better to retain the frame because that gives you the optimum environment to consolidate early and the patient. So the conclusion is that Ilizarov methodology is a versatile tool for tackling deformity of varied etiologies and complexities. We do not need much more hardware. It has enough and more than enough things. We just have to think about the soft tissues and the rates of the soft tissue. That is never been received much attention. And guidelines for addressing this soft tissue factor in deformity correction is further research. That is all deformity correction is all about. As far as I understand, this complex geometry is not much needed.
Thank you very much, Dr. Jishnu.